Well, welcome everyone to another webinar on highlights in neurosurgical oncology. Today we have a special guest, Dr. Shawn Hervey-Jumper. He's a Mitch Berger Endowed Professor of Neurosurgery at UCSF. He's a Medical Director of Neurosurgery, Associate Neurosurgery Residency Director, and he's an NIH-funded lab with a clinical practice focused on the surgical management of patients with brain cancer within functional areas in which he uses physiological mapping. His lab seeks to understand the causal mechanisms of brain cancer-induced neural circuit remodeling, and he aims to uncover molecular drivers and therapeutic targets of activity-dependent tumor proliferation and cancer-induced cognitive impairments. Through these efforts, he has served as a PI for numerous clinical trials. His lab has identified drivers of clinical trial enrollment for patient populations that are vulnerable. He teaches neuroscience, cancer biology, and research ethics courses at the graduate school. And he's led multinational educational efforts in scientific and professional societies such as SNO, the tumor section, including being the chair of the scientific program chair and subspecial track chair, and many other accomplishments. He's going to be talking about surgical management of diffuse gliomas in the molecular area, which is a critical portion of area of what we're doing right now. And without further ado, please, Dr. Hervey-Jumper, we're very happy to have you.
Guys, thank you so much. Can you hear me okay? Great.
Yes.
Everyone, thank you. This is such an honor to spend a few minutes chatting with you. I know it's the middle of everyone's day, middle/end of everyone's day, so we're all busy. But taking this few minutes to talk about something that's important, I think, to all of us. I have no disclosures. So, I just last night put together some images that all of us look at every day, right? This is probably pretty emblematic of your clinics over the past, several days or weeks. And in each of these situations, we're looking at these scans and immediately, right, our minds are going to, I would operate here or not operate here. And these are the goals I would have based on features of the patient. And it's just been increasingly interesting to me to want to understand how we make those decisions and what influence our surgical resection should have in light of what we now know about the biology of the disease. And let's start on the right side of the screen, where we know that all current consensus guidelines are that from all neuro-oncology or oncology support groups and organizations, is that extended resection matters, both with respect to tissue identification. But if we go to the left side of the screen, this is a figure we put together for a paper. I was actually just accepted yesterday, trying to help us understand what are some of the molecular features that drive both the impact of extended resection on outcomes, but the influence that these molecular features have on extended resection. We know heterogeneity with respect to differences in cell state. We know that renal resect criteria has helped us identify which categories or classes matter for extended resection. With respect to survival outcomes, we have ways of measuring some of these biomarkers and outputs. But for the purposes of today, I want to focus really on molecular features associated with neuronal integration, and then what that might mean for extended resection, or what our extended resection goals might be. And this is, I'm going to summarize basically some of what we'll talk about in this kind of busy slide, where, again, we know that brain tumors, to state the obvious for neurosurgeons, we know that brain tumors are, on some level, for certain types of tumors, functional units of brain, right? They have a role in human behavior and glioma proliferation. We know, broadly speaking, that both excitatory pyramidal neurons and inhibitory neurons influence glioma biology. Specifically, that's been suggested mechanistically to be involved in cancer initiation or glioma initiation, tumor growth and invasion, but as well as therapeutic resistance through these gap junctions between cancer cells called tumor microtubes. We know also that cancer cells, particularly glioma cells, make a bunch of things that look just like glutamate and act just like glutamate and make neurons hyperexcitable, not just with respect to seizure activity, but cognition and cognitive impairments. My lab has really been focused on this idea of the synaptic inputs in cancer, particularly glioma malignancies. And outside of this synaptic influences, a lot of this nervous system regulation of cancer is focused on synaptic features. So my lab is really focused on using advanced signal processing to decode electrical activity from cortical regions. We have a huge data set for this, and now it's close to 150 people, thousands of electrodes, many hours and units that are recording from, and turning these electrocorticography signals into meaningful sets of data that we can answer questions for patients, again, mostly obtained under clinical context. And so this is kind of where we started. I'll start with kind of the three-part, 30-minute talk, focusing on glioma-infiltrated cortex and does it engage in task-specific behavior and how. Then we'll focus a bit on extended resection for low grades and for high grades and how that's influenced by this synaptic integration idea. So let's start with this. Again, most of you are familiar with all of these folks on the screen. I just want to put this up, this amazing book to the left. It was one of the first books I ever read in terms of systems neuroscience. Suresh Ramnath, a faculty at University of Michigan when I was a resident, gave me this book, Speech and Brain Mechanisms by Wilder Penfield. It's a really fascinating book if you ever get like a afternoon to read through it if you haven't. But it really maps out part of the reason that we have not put a lot of investigation as a field, and as a neuroscience field, into human glial neoplasms, particularly gliomas. He really maps out this idea that epileptic regions and areas, epileptic regions are kind of representative of how the brain works, but neoplasms, particularly glial neoplasms, are just so disorganized, we couldn't possibly understand them. But on the right side, I have some of the kind of fundamental work that's helped us understand where words and speech are originating from in the human brain. And interestingly, what snuck into there is a lot of recordings from glioma patients just not looking at normal regions of cortex. I'm sorry, just looking at normal regions of cortex. So this idea of using, again, subdural high density or medium density electrode arrays in a awake behaving patient for task-specific behavior and answer questions related to that was an interesting part. And as I started my lab, I really focused on using glioma patients with the thought that we would just use normal appearing electrodes, nothing that's infiltrated with flare, and everything else we would throw out. But on a whim, kind of literally one afternoon, we decided, well, let's just look at this and see what happens. And lo and behold, these are high gamma power activity. This is looking at high gamma power because it's close proximity to neuronal population spikes in the time series of speech activation just for motor speech planning and Broca's dorsolateral prefrontal cortex, just saying a word across subjects. This is an experiment of 14 different people. And you look and see this high gamma power of increased high gamma power in the area anterior to primary motor cortex that suppresses after speech initiation. And this behaved in an identical manner to normal appearing regions of cortex. So this is the brain that was supposed to be disorganized and garbage brain that we kind of we removed surgically, and that has been discarded and not studied for many years, 50 plus years. So that was quite interesting. I said, well, heck, well, that's a little troubling. So let's pair match each electrode. There must be a problem here. And not only that, do we see, preservation of task-specific responses in glioma-infiltrated cortex, but you saw hyperexcitability of increased high gamma power relative to normal appearing regions of brain. Again, highly uncomfortable at this point to say, well, we know our patients have impairments. Why might this be? So we put the system into overdrive and asked the participant to not just study or not just perform simple aspects of cognition, meaning simple tasks, but we broke out each elemental picture, auditory visual picture naming, into more complex aspects. Poly versus monosyllabic words, high versus low frequency words, and then train classifiers to predict word condition. You can see, as you would expect, in normal appearing regions of brain, a mono versus polysyllabic word, right? Saying word cat versus aardvark takes a greater computational strength, right? Or greater increase in high gamma power in the polysyllabic word, but normal appearing regions of brain, glioma infiltrated cortex could not computationally do that. And as you might imagine, to train a classifier for word condition in normal appearing regions of brain in cancer patients is possible, not possible in glioma infiltrated regions of cortex. And as you might imagine, you have decrease in information content. This is the Shannon entropy measure across your time series, seeing a decrease in your entropy values in cancer infiltrated regions of cortex of brain tumor patients. So this idea that these are functional units of brain, and to some extent, but there's a loss of information encoding within these cortical regions, was again pretty compelling. At least wanted us to maybe wanted to learn a little bit more, think a little bit more about this. So we said, well, let's sample these cells, right? With the idea that maybe some of our populations of glioma cells may function in the tripartite synapse similar to normal astrocytes, right? We know that astrocytes are a big part of this. And if glioma cells are one of their cousins, then we say, well, maybe there's some similar behavior. And lo and behold, this is bulk and single cell RNA sequencing. So a number of different transcriptomic profiles, including a synaptogenic population of glioma cells that particularly were positive for this molecule thrombospondin 1, and which is associated with new synapse formation. And you can see within these highly connected functional regions of glioblastoma relative to normal, relative to poorly connected, also I'll call LFC connected regions of glioblastoma, you can see an increased synaptogenic profile, pre and postsynaptic puncta, and this population of glioma cells are just uniquely molecularly distinct. They proliferate only in response to neuronal signals. They're more invasive only when they're surrounded with neurons, and they form these tumor-type connections, junction connections, and they form synapses with these normal neurons that kill the animal faster. So this idea, again, of having a functionally integrated glioblastoma was quite interesting. And we again, taking it from mouse, where you can, again, take xenograft primary patient-derived cells with these HFC regions, increase in tumor burden, the mice die early, associated that into patients, and quantifying whether they have a functionally connected tumor versus a poorly connected tumor or a normal connectivity. These HFC voxels, as measured by imaginary coherence in glioblastoma patients, was a poor prognosticator. These patients are folks who died sooner when you control for all matched variables. As a matter of fact, I don't usually trust just standard survival analysis. I really like different, recursive partitioning and others. If you can get a cohort matched even remotely equally, you throw in again into a population of homogeneously treated, all with the Stu protocol treated glioblastoma, matched for size, etc. The primary drivers or primary nodes using recursive partitioning became age, extended resection, and the presence or absence of HSC voxels within the tumor. Remember, these were all people that received temozolomide. So prognostically important, right, in patients, which seemed pretty undeniable at that point. And one of the reasons I wanted to start with this, because this idea of synaptic connectivity or synaptic integration in glioma malignancies has really become quite important, I think. And I really love this paper. I'm not sure who's seen this, but this is Richard Drexler's paper. This is the Hamburg, Germany group just did a lovely job about almost a year ago now, of integrating and quantifying glioblastoma samples as whether they have low or high neuronal signature based on DNA methylation. And not only did they see, similar to our model, an increase in survival associated with the low neuronal signature relative to high, we then also, again, cross-validated their samples with ours, and sent our set of samples for DNA methylation and showed the same sort of effect. But they demonstrated that GTR plus, or gross total resection, outside of the imaging confines regions of the tumor, was most protective or most helpful in those patients with a high neuronal signature. So this idea that, again, the decisions we make surgically may be influenced by, it should be influenced maybe to a great extent by these molecular features, including the synaptic integration. And this is meant to be a short snippet, so we'll just focus on the synaptogenic story. So with that in mind, again, what is our data, or what evidence do we have about maximum resection and the survival benefit associated with patients? And we know there's quite a bit of data based on multi-center, multinational epidemiology studies produced by many of the folks in this room that are looking at more than 25 plus high volume high value publications. I just put a couple in here. Over the years, we know that our extended resection threshold started with a 98% of the T1 post-GAD contrast enhancement, and it's gone to this like muddy idea of flarectomy, flare resections that I just want to talk about a little bit in terms of what we're trying to accomplish here. So again, I only put this up here because I just know this data really well. It's been 2 years of my life flogging through this with a net ball and arrow. But this general idea that you can take patients, again, using recursive partitioning based on, this is roughly 500 plus patients, UCSF discovery cohort validated. This point was at Cleveland Clinic, Case Western, and the Mayo system. Outcomes predominantly driven based on temozolomide use, IDH status, age of diagnosis, in this post-op non-contrast enhancing or flare removal with this volume. What struck me really with this study was really just this blue line, for the point where, again, for a select group of patients who are under the age of 65, survival outcomes were nearly identical at 2.5 years for patients with an IDH wild type, at this point glioblastoma, or IDH mutant, WHO grade 4 astrocytoma. This was right before the 2021 diagnostic criteria, relative to a GBM. These folks, these lines lived together for 2.5 years with extended resection of flare, which I thought was super interesting. So that at the point became our mark, right? If you can do it, if you're under the age of 65, you want as much extended resection of the contrast and non-contrast enhancing tumor as possible, as opposed to over the age of 65. We think the RANO-RESECT has kind of put a little light onto that, which we'll talk about in a moment. But I'll introduce, this is the Quinones paper. Again, one of my favorite papers published in JNS in the last couple of years. This is a 2022 publication. And if we think about extended resection of flare as a dose of drug, right, or just a volume as a dose of treatment, shouldn't more extended resection be protective? To some extent, maybe, right? Well, let's challenge that. So we can clearly see a super maximum resection, at least of greater than 20%, is protective. But what we don't see is that these hazard ratios drop. These hazard ratios pretty much plateau. So I don't know that we can say that 50% of flare is better than 20% of flare. I'm not sure that it may work like that, but it certainly doesn't seem to be that sort of relationship. As a matter of fact, over 60% of flare removal no longer is a survival benefit with a, again, hazard ratio that goes up. Again, most of the folks in this room have contributed to the RANO-RESECT data to help us understand and just lump our data together, which has been super interesting. And it gave us definitions, right? Class 1 with a super complete resection of this much of non-contrast enhancing disease, all the way to class 4 of a biopsy, and we can see the survival benefit associated with that. Again, great work here. This begs the question of what's the influence of neurologic impairments on these survival outcomes. Again, this is one of my favorite papers to this. This is Marion Rahman's paper. This is pretty old now, 2017. And I think it did include some what are now classified as grade 3s in here. So you have to be a little careful, but I think it's just a powerful message here. You can see, again, greater than or less than 95% extended resection, no neurologic impairments with a greater than 95% extended resection, great, right? Everything shifted to the right. Look at the red, right? Less than 95% with new neurologic impairments, bad. And then you get this washout effect, plus or minus neurologic impairments that you can see. So it led us to this idea that causing permanent new neurologic impairments to push that resection could actually be harmful to our patients. One challenge I've always had with this sort of work is that these are unequal cohorts, a little bit of apples and oranges, right? Patients that come in with bad impairments don't necessarily get temozolomide treatment. So we said, well, we have a ready-made data set. You convince a resident to focus on this paper. This is Alex Abetti. Said, all right, let's take everyone who did not get temozolomide and kick them out. And also all your IDH mutant WHO grade 4 astros, since obviously several months after we published this paper, it became irrelevant because of the diagnostic criteria changed. But if we focus again on this homogeneous population of glioblastoma with plus or minus gross total resection, and we input new neurologic impairments plus or minus, we can see that our RPA is really focused now on, again, the contrast enhancing tissue removed, non-contrast enhancing tissue removed, and now neurologic impairments more than age or any of the other 55 prognostic variables that are included in the model. So again, even with a homogeneous population of people, we know if we cause new deficit in our patients, it's quite a problem that we need to be careful about. So as we push the resection out and try to think about GTR plus, even in our molecularly problematic or concerning patient cohorts, we just need to be quite careful about how we do that. A little bit about IDH mutant low grades, since that's generally, as we know, a hot area. Again, this is tricky, right? Because we have everyone from 18-year-olds who come in with lethargy to, brand new college students and, folks who are even, at the end, maybe towards the end of their working years. And our goal is pretty straightforward, right? We need to keep all these patients as much as possible working, leading a good quality of life. Most states, if you have an IDH mutant grade 2, you can't file for disability, right? You don't get a lot of resources. So these folks really need to work and maintain as functionally active as possible. I think Tim Smith was the first on the block, post WHO 2021, if I'm understanding this correctly. And he published, they published a couple of really nice papers on this. This is single center data suggested that, resection enhances overall survival and delays time to malignant transformation. And these are the prognostic variables, again, for IDH wild type, for IDH mutant, oligos and astros. Tim was nice enough to, partner with us so we could have an external validation data set. This is the JCO paper published now, roughly a year and a half ago. Actually, almost 2 years ago, geez, from focusing on roughly 450 patients with IDH mutant oligos and astros. This RPA is a little busy because there's a couple of historic artifacts left in here. The presence or absence of chemotherapy was based on RANO criteria. RTOG and RANO criteria that really selected certain high-risk patients based on features that we don't necessarily fully believe are high risk anymore. So these folks got temozolomide and PCV up front. So it's hard to bleed that out of these retrospective data sets, which is one critique of this data. But let's kind of walk through this. Pre and post-op volume and molecular subtype drives overall survival in this curve. You can see here 3 risk groups: worst, big oligos with less extended resection, best are big astros with less extended resection. Best group are any oligodendroglioma, and smaller astros with greater extended resection. So this idea of a survival benefit associated with extended resection is important. And I should say, heading into this idea that extended resection mattered for both groups was really an open debate in my mind, right? There was 4 papers that said, yes, both groups benefit from maximal extended resection, and 2 that suggested that it's only beneficial in patients with astrocytomas. So we wanted to challenge that a little bit by introducing this GTR plus idea. Again, this is a resection anything outside of the imaging defined tumor margins for patients with presumed IDH mutant tumors. This is I call this the surgeon's view, because this is patients with oligodendrogliomas and astrocytomas together, even though we have some idea of what we're operating on now, but not always. Lumped together, we can see gross total resection plus relative to gross total resection, relative to 99% or less extended resection, a survival benefit for each. I think it's important to mention, I mentioned this 3 times in clinic today, that this survival benefit of GTR minus versus gross total resection is after about a decade. So that 19-year-old that we're seeing talking about whether or not to impair hand or limit their typing during their college years need to know that their life for the next decade is probably going to look pretty similar. What we're talking about is beneficial, more maybe up to a decade from now. So we need to think about that carefully as we talk about the risk we put patients through. For astrocytomas, again, we know that extended resection outside of the imaging defined margins could be beneficial at 20-year survival relative to gross total resection. Oligodendrogliomas, this study capped out at 20 years. GTR plus and gross total resection co-localize, both better than 99% or less. We need to give these folks a good resection in their oligodendrogliomas. You probably don't need to push outside of the imaging defined margins, at least as supported at 20 years. And IDH inhibitors put in, important caveats into that we'll talk about in a moment. So again, I think we have a few more minutes. This progression and malignant progression-free survival data is always super tricky for me to interpret, right? Dashed line, we can all agree on when patients pass away. Solid line, progression looks a little different, even when we're all using the RANO criteria, right? It's not perfect. So for the next couple of slides, just realize that progression-free and malignant progression-free survival is lumped together to just distribute the noise across the whole cohort. We can see here, though, again, progression-free survivals based on oligo versus astro, no surprise. But our risk groups also separate by post-op volume at these measures here. And malignant transformation-free survival, again, similar story with an age cutoff of 43 before the malignant transformation. Possibly the most important part, and the reason we wanted to, sink a lot of effort into this was because a clinical trial for this is hard, if not impossible. So we wanted to have a large enough data set to run propensity match scoring analysis with a cross cohort. Again, you can see here, again, the extended resection threshold. If you go from 65 to 100% extended resection, your hazard ratios become significant and begin to drop at about 75% extended resection. And if we focus on the blue line here, our confidence intervals, entail you can see it gently drifts towards the left with lower hazard ratios beginning at that 75%. So that's what I tell patients is the goal, 75% or greater. All of that, I don't want to say goes out the window, but we have to be careful how we think about this in light of, the next several years where we won't know the impact of early use of vorasidenib because it was outside, or IDH inhibitors in general, because it was really outside the confines of the study. And most of our patients, as we all know, if I ask everyone to raise hands if your patients are on, vorasidenib after anything less than a gross total resection, we'd all probably raise our hands, right? These patients are now just put on drug. So we'll have to figure out what that means in the future, which will be a little hard. But again, I hope this helps us think through, again, as we're looking at these patients, what are our goals? What are we trying to accomplish for them? Not just in light of, targeted molecular therapies, but in light of, again, our molecular understanding of disease as surgical oncologists. I think our take-home point is that, again, surgical goals are a little more nuanced in light of this day and age. We do have some tools to help us distinguish what molecular classification, or at least histologic classification, we're talking about. Again, I wanted to, leave plenty of time for discussion, so we didn't go into all those tools. This idea of synaptic integration is near and dear to my heart. I think it's a really important influence on outcomes and can influence surgical decision-making. I think gross total resection is important for certainly a select group of patients, probably not all. I think pretty clearly patients with IDH mutant astrocytomas, if it's feasible, and certainly patients under the age of 65 with a glioblastoma. And we have to, interpret and think carefully about whether that's really our goal and at what risk for patients outside of that. So, folks, thank you. I hope we have enough time to at least have a little bit of a discussion. This has been an absolute honor, and I really appreciate the organizers for giving me a few minutes to spend with you.
This was a great, thank you, Shawn. I have a question on the first part of your talk in terms of the outcomes for the functional integrated gliomas. Why do you think that there's a difference? Is this because of cognitive deterioration, response to chemotherapy, radiation, or what are your thoughts?
Yeah, so, Frank Winkler is kind of one of the early pioneers of this, gap junctions between glioma cells that propagates the synaptic inputs. That's the idea. And you can measure these in tissue. And his thought was these synaptically integrated gliomas through gap junctions were more concentrated in the center of the tumor. His thoughts were that as you get out towards the periphery, you're probably removing more of the connected glioma cells. I'm not sure if anyone's read any of the papers that have come out of his lab. It's really fascinating stuff. But the idea is that we're resecting more of the connected glioma cells, which tend to be at the periphery of the tumor. And so we're biologically influencing, outcomes just by removing some of those cells that are offering the treatment resistance, and therefore, propagating the, treatment resistant mechanisms and things like that, which is where they recur. And that also explains, or if that theory is correct, may explain why these patients tend to recur at the margins, right? Not just that we're leaving tumor, but we're leaving the tumor that's also connected, that's going to be driven by the inputs of neuronal activity as well. Just a theory. We have some preliminary work to that extent, but certainly not completely tested at this point.
Sure. Raj, Ashish, any comments?
There's a question in the chat. Great talk, by the way, Shawn. Really enjoyed it. And
stop sharing. I can see everyone.
Great to see.
Great to see you, man.
Yeah. So there's a question in the chat about your thoughts on vorasidenib in low-grade gliomas, especially in pediatric cases, because there's not a lot of data on that, and what you think, if it's safe.
Yeah. Well, yeah. Whether it's safe or not, I don't. Yeah, I know this is recorded, right? Yeah, so I have no idea. I have no idea. But certainly in the AYA population, it's it makes sense. We do have to be careful, right? Here are the caveats we have to be careful of, right? Nothing about VORA or IDH inhibitors was really tested in women of childbearing age, or meaning not women of childbearing age, but the teratogenic effects on pregnancy are completely unknown. Other part is natural history, right? This is a 14, 16-month study for a 20-year disease. So, I don't know anyone who went to Snow this year. Martin Vanderment gave a really important talk, right? And his talk was kind of cautioning us a little bit to say, like, we have patients who will hang out for 10, 15 years with their disease with no treatment. And now all these folks are put on drug. Is that a good thing?
Yeah.
Right? And he's right. We don't, impossible to know, impossible answers right now. But
And that kind of brings me to my next question is, the design of the trial, which I thought was, interesting because it was compared to basically placebo alone versus what we do is standard of care if we have residual or progressive IDH mutant, a lot of these patients get on treatment. And so I don't know, this is like a, a topic we always talk about in tumor board is, and the radiation oncologists, they have a little gear to grind on it. So what are your thoughts on controlling in that setting?
yeah, well, obviously that's super true. And it gets to the point where, right, if you look at the established guidelines right now for SNO, ASTRO, ASCO, and probably tumor section, they all differ in terms of like when radiation is given, and the treatment pipeline. NCCN, I think, is updated now, but we don't even have cross specialties homogeneous guidelines right now. So it's a little bit of the Wild West. In terms of study design, I think it's brilliant, mostly because they took patients that were sitting around in clinic doing nothing, right? And to me, one of the biggest take-home points of this study is that these are people who do not have indolent disease. Until this study, I told every patient, like, we're going to remove your tumor and you're just going to like hang out for 5, 8, 10 years. Look at the number of events like in those Kaplan-Meier curves. That is undeniable, right? These people had a lot of events. So that is undeniable. How we interpret it, though, right? The logic is like, if you leave a little residual, which many of us do for many reasons, right? As we counsel our patients, do we wait for it to grow or do we put them on drug? And the consensus opinion kind of nationally for most of us seems to be to put them on drug. And that's the gap, right? That study, as you know, didn't address it all. So I think it was a really smart design in terms of finding a captive population of patients that was literally sitting around. But they're kind of victims of that now because the study only lasted like this long. And now we're left with like, what do you do with it?
All right. Good points. Thanks.
Yeah.
Do we, Yasha, do we have time for one more question or not so much?
Yeah, go ahead. Let's do one more question. I think that's fine.
So Shawn, thanks for being here. Great talk as always super thoughtful and thought-provoking. A practical question that comes to mind for me that I think maybe some of the younger people in the audience might be wondering is, with all the data that is out there, practically speaking, at a high volume, high tech place like UCSF, when you're in the operating room and you have a person that has a presumed primary glioblastoma in a quote unquote non-eloquent part of the brain, like a right frontal, anterior right frontal kind of thing, what is your approach to that case? Are you going into it knowing you're going to do a supramarginal resection? Are you doing, are you looking at 5-ALA? Are you looking at some intraoperative adjuncts? What is your workflow to try to get that person the best outcome?
That's a great question. So again, I don't, in the beginning, were you talking about IDH mutant or IDH wild type?
I was thinking about IDH wild type.
Wild type. Yeah. So obviously it depends on location. I don't know if this is fair to do, but I do, as much as I can, I want to understand what the patient's goal is. At our center, 20% of patients return to work. And not because, as we know, right, not always because they can't, but because it's like a full-time job to get glioblastoma treatment, right? It's just complicated with a lot of moving parts for most people. If their goal is to return to work and they're of working age, and that's like super important, then we're going to maximize how much we can remove, but I'm going to try to, those short-term neurologic impairments, I'm going to be more cognizant of because of that concern. So how am I doing that? I guess is more of your question. Standard awake craniotomy if it's dominant hemisphere. I'm not a non-dominant awake person. Most people on the right side, unless there's a compelling reason, right parietal or ambidextrous or whatever, they're usually asleep if they're on the non-dominant side. Left hemisphere, awake language mapping. If it's in motor cortex, I actually do that more asleep with motor mapping now, mostly because it's just monopolar stim. It's just a little easier within a sleep patient. But cortical stimulation mapping, subcortical stimulation mapping, we use a lot of optical imaging. I just find that the tumor margins or some measure of that is a more granular data point than fluorescence alone. And so, but it's investigational. Like, you know, I don't tell patients that I can do that as part of standard of care, but I use that a lot. 5-ALA, we use that as well. And just all that, just the bread and butter stuff that everyone else is using. The rest, some adjuvants that are kind of investigational on top of that as much as I can. Did that answer your question?
To complement that, Raj, if we look at all those studies, and as Shawn was mentioning, short deficits or even judgment, personality changes are going to affect the patient. But none of the studies that have been published in terms of super maximal, super total, even the Rano study would have assessed cognitive function in a reasonable way. So I think that's the next step, that we really need to know the cognitive deficits of doing this approach, which are not negligible. And, you know, as you know, every part of the brain has function. I don't know that there's a non-element in that area. But anyway, I think this is a great conversation. Thank you so much. And hopefully we'll see each other in the next highlights webinar. We're having this every 2 weeks. Everybody's invited. Please promote it with your students, residents, colleagues. And we'll see everyone at tumor section at AAMS. Thank you.
See you guys.
Thank you.
And the webinar will be recorded at YouTube. So for everyone who didn't get a chance to see it, and that's a great way to catch up on this as well.
Awesome.
Thank you so much.
Thanks, folks.
Yeah.
Thanks.